Welcome, everyone. My name is Ashani Johnson-Turbis. I know and believe that we are live. I see lots of folks joining. We were at 35 participants, 44 participants, 48 participants, and I'm certain that this will keep growing. So excited to have you here. So we are honored to welcome you to our Society for Health Communication webinar in partnership with CMR Ignite. This webinar will be on education and outreach strategies to support state and local opioid prevention, treatment, harm reduction, and recovery. And we have an awesome moderator and an awesome panel prepared for you today. Let's go ahead to the next slide. So in order to get just a little bit before we get started, I want to say a little bit about the Society for Health Communication. As I stated at a moment ago, my name is Ashani Johnson-Turbis. I serve as the president of the Society for Health Communication. We were founded in 2016, which makes us, we're about to come up on our 10-year anniversary next year, which we're very excited about and plan to have some celebrations for our 10 years. But founded in 2016 to unify and the field, the health communication field, across industries and behind one singular vision. I like to often say out loud, the Society for Health Communication, we are transdisciplinary in terms of the people that participate and are our members, our individual members, our organizational members, our steering committee. We are robust and diverse in that regard. Our mission is to bring together health comm professionals and scholars. We really want to create meaningful connections, create forums for learning, such as the one that we're in right now, share knowledge across our multiple disciplines, promote health equity, and advance the science of health communication. That last part I'll say twice because it's particularly important. Our job and our role as a society is to advance our field of health communication. We are very proud that this year we made it to over 6,400 individual members, and we have 30 organizational members, and we are continuing to grow. And like I said, that's across multiple sectors and disciplines. Let me just highlight the amazing executive team that works at the Society for Health Communication. I serve as president. Stacy Robison, you'll hear from her a little bit later at the very end, is our vice president. Stephanie Miles is our member at large. We always like to engage a past president, and that is Michael Grilla. Our executive director is Dana Chomenko, and we have a wonderful communications director, and that's Diane Brodowski. Go to the next slide. I'll do a little housekeeping before we proceed. All attendees are automatically muted. We are recording this session. You heard at the top, recording in session, which is a familiar sound that folks hear now. We will make this recording available on the Society for Health Communication website and the slides in the coming weeks. The chat function is open. I like to always encourage folks. Some of the best conversations take place in the chat. So please use that for discussion and for connection, right? This is a forum for connection. Submit your speaker questions through the Q&A function under webinar options at the bottom of the window. We'll also observe in the chat if folks want to pop some questions into the chat as well. Send a chat message to the host if you have any technical issues at all, and we will respond as quickly as possible. And press the CC icon in the bottom left to turn on closed captioning. For some people, that's in the bottom left. For others, I know sometimes it's in the bottom right, but that's the button to click if you want closed captioning. Next slide, please. At this point, I have the honor of handing it over to Brittany Bethia, who will serve as our moderator, and she will introduce our exceptional panelist for our discussion today. Brittany, the stage is yours.
Thank you, Ashani. And I really want to welcome everyone to today's event. As a steering committee member here at the Society for Health Communication and co-founder of the Opioid Use and Recovery Alliance, I'm really excited about the conversation that we'll have today. As many of you know, September marks National Recovery Month to raise awareness about substance use and recovery, as well as to promote our recovery efforts that we're collectively engaged in across the country. Our conversation today will provide an overview of the substance use landscape and how it's changing, as well as discuss treatment opportunities and gaps. And then we'll also highlight the role of communication and outreach across the continuum of prevention, harm reduction, treatment, and long-term recovery. Lastly, we'll close out by sharing a few resources to help you with your efforts as well. So before we get started, by way of the chat, feel free to chime in to let us know if your city, your county, or your state currently has an opioid education campaign. We also would like to know, just to get a pulse around the room to help us gain a better understanding of the perspectives and experiences online, who might have been impacted by a family friend, a loved one, or a other individual in your community who is impacted by the opioids crisis. Next, I want to go ahead and start to introduce our esteemed keynote speaker, Dr. Wilson Compton. Dr. Compton serves as the Deputy Director of the National Institute on Drug Abuse, or NIDA, of the National Institutes of Health. In his current role, he is responsible for including a portfolio of work to provide scientific leadership in the development, implementation, and management of NIDA's research portfolio to improve the prevention and the treatment of drug use and addiction. So welcome, Dr. Compton, and thank you for attending. I'll go ahead and turn it over to you for your presentation.
Well, thank you so much. It's really a pleasure to join you and all the listeners today to provide a brief update around what's been a public health crisis in the United States. It turns out this crisis has been going on for some 40 years. We've been paying particular attention to it for the last 20 years. But if you look historically, we've seen that this drug overdose increases started back in the 80s and have progressed since that time in a massive increase over every year and every decade. Now, there have been major changes in the drugs that are involved in this and the populations affected, the parts of the country affected, but the overall impact on the United States has been remarkably devastating in terms of the number of people that are dying from drug overdoses. Now, as I've just mentioned, this epidemic has shifted from starting first with the cocaine epidemic in the 1990s, but most of the attention has been on the opioid period, which spans the last 20 years, with market increases in prescriptions for opioids. Turns out that a number of those were misused and diverted to illicit drug use and caused problems on their own. So we saw a market increase in overdose deaths due primarily to prescription opioids for about a decade. As we've begun to get a handle on that and reduce the overprescribing, the epidemic shifted. Those millions of people that had developed a habit from their prescription opioids, many of them shifted to heroin. Either they had used both and found the pills easy to obtain, and they went back to heroin, or they started down that heroin pathway with all of its devastating consequences. Unfortunately, the drug market has changed. We've seen major shifts with the availability of synthetic opioids is a major term for what we mostly refer to as fentanyl. This is not the fentanyl that's used for end-of-life care or as part of anesthesia, but this is the fentanyl that's produced in illegal laboratories and then distributed, much like heroin has been, through drug purveyors and marketers all across the country. Unfortunately, that hasn't happened without consequences, and we see this market increase in deaths from about 2013 through around 2022. Now, I want to look at the last part of this curve, though, because this is very good news. We've seen that in the last year, year and a half, a market improvement, about a 25% reduction in the last year in terms of the number of overdose deaths for the previous 12 months. So that's really positive news for our country. Although I like to pause and reflect a little bit here. If you had asked me 5 years ago if I would be excited by only 79,383 overdose deaths in the 12 months of 2024, I would have thought there was something wrong with you. I am still horrified by these remarkably devastating consequences to families, to offspring, to neighborhoods, to communities that we see with 80,000 deaths in the last 12 months due to drug overdose. So our work is certainly not done, but it is gratifying to see some improvements. And if we see continued improvements like this, we'll be seeing, if not an end to this public health crisis, but at least bringing it down to much more manageable levels. Next slide, please. Just to look at some of the details, some of the good news is that these overdose deaths have declined in all the major categories involved in causing drug-related overdoses. So we've seen particularly I want to look at the column labeled synthetic opioids, which would be illicit fentanyl. About over a third of those deaths have a third fewer deaths in the 12 months ending in April of this year than in the 12 months ending of April of 24. So that's really been a remarkable story. I will point out that while we've seen reductions in cocaine and particularly methamphetamine related deaths, for methamphetamine, the declines have not been as significant. And so we still have quite a bit of work to do. And I'll come back to that in just a moment. Next slide, please. I hope I've suggested to you, just by looking at that curve of overdose deaths, that the drug epidemic changes over time. Some of this is due to what I think of as market forces, or some would call this the vector of drugs in our country, the drug dealers, drug sellers, whether that includes the legal manufacturers of prescription medications that engaged in egregious marketing practices, or more recently with the illegal drug sales that have really progressed and have shifted to particularly dangerous products. But now we're seeing a market increase in methamphetamine involved, both hospitalizations, and I showed you some of the death reports. You may have been hearing about xylazine as a contaminant in the illegal opioid supply. This surprises certainly me and many, because xylazine in and of itself is not really an addictive substance. It's an animal tranquilizer that's used in veterinary medicine. It's not approved for use in humans. Of course, whether something is approved or not for use in humans is not usually a concern for the illicit drug market. But adding it to the supply was first seen in Puerto Rico some 10 years ago, but more recently we've seen it particularly in the East Coast, but now we're seeing it all across the country to varying degrees. So this is an example of how you need to pay attention to what's happening to the drug crisis in your particular community, neighborhood, urban area, or state in order to understand what you need to be addressing with your clinical interventions. Next slide. Other ways to think about some of the changes are we've seen the emergence to a small degree, but this is potentially very concerning, of new opioid agents, a whole category of chemicals called nitazene compounds. And these are produced in a different way, so it's a different set of precursors. And they can produce the same devastation that we see from fentanyl, heroin, or other opioids. So this is something that we're certainly monitoring, and we hope public health officials all around the country will be paying attention to. We've seen some, outbreaks of carfentanil exposure. Carfentanil is related to fentanyl in general, but it's an even more potent version of that. Fentanyl compounds come in a variety of subtypes, and carfentanil is particularly concerning because it's markedly more potent than what I think of as sort of standard fentanyl. MDMA has shown some increases. Medetomidine is an agent much like xylazine that is a sedating agent that has some of the same chemical properties as xylazine. And we started to see that taking the place of xylazine in some communities. Many of us still don't completely understand why the drug dealers are adding these agents to their opioids, but we certainly observe it happening in so many different jurisdictions. Next slide. So what are we doing about this? Well, of course, we're focusing on how to save lives acutely. I can't do psychotherapy. I can't help you with recovery if you're not alive. And so our first challenge was, how do we make sure that a medication, naloxone, that's been available in healthcare settings for some 40 years or longer, is readily available out in the communities? After all, when somebody has overdosed, their breathing stops. And you can survive without breathing for a few minutes, but not longer than that. So that's why getting care out to where people have overdosed has been so important. It's much like our push to get the AED devices out in so many areas, so that if somebody has a heart attack, you can get help to them immediately. It's very similar with availability of naloxone. Now, the injection form has been available for some time, but we're really pleased that in partnership with the National Institute on Drug Abuse, the nasal spray version was developed, which has now gone into very widespread use and is available over the counter without even a prescription. Prior to the over the counter availability, there was a lot of general availability because this is quite a safe medication. It has some side effects, but they're rather minimal. And certainly the life-saving potential far outweighs any risks or concerns. Next slide. In addition to that focus on saving a life acutely and making sure that persons at high risk, as well as their family members and communities, have access, we've been focused extensively as a field in making sure that medications are readily available. I love this headline from a National Academies of Medicine study that reminds the clinical world and researchers that medications for opioid use disorder save lives. So that's why we've been working to increase access and availability to buprenorphine, to methadone, to extended release naltrexone. Unfortunately, we still only see a minority of persons with an opioid use disorder using these medications. And so we have a lot of work to do to both convince people to try them, start them, but frankly, if you don't stay on it for months or years, typically, it won't have the benefits that we'd like to accrue for our patients. Next slide. The other way that our agency has been focusing on this has been to emphasize what we call implementation science. So where are our patients showing up? They're showing up in emergency rooms, in criminal justice settings, in broad-based out-of-treatment community settings. So we've launched major programs to do high-quality clinical trials in emergency departments or with clinicians to develop new treatments. We've had a major initiative called the Justice Community Opioid Innovation Network, or JCOIN, that has really helped improve the outcomes for persons who are incarcerated, on probation and parole, or otherwise are involved in justice settings, to make sure that this high-risk population, that when they have an opioid use disorder, that they have full access to the treatments and the medications that can help them turn their lives around. We've seen some market improvements in that space, and our initiatives, we are part of that, pushing increased knowledge and outreach to change those patterns. And certainly focusing on broad communities and how we bring the full range of opioid interventions to communities has been a major emphasis, such as our Healing Communities study. Next slide. Now, I'm going to wrap up with just a little more information to remind us that, many in the public think, oh my goodness, there's nothing I can do about this. This is an incurable condition. Well, I don't really have cures, but we certainly have recovery support. And we understand that most people with addictive disorders, given attention and support, will be able to turn their lives around. And that surprises many in the public because they mostly recall the people that struggled and didn't turn their lives around. But there are millions and millions of people who are in recovery, who previously had problems and have found ways to turn their lives around. This is just an example of how work from my director, Dr. Nora Volkov, has documented that even the brain can recover over time. So it's an important message that healing can take place. Next slide. As we focus on this, though, we need to be paying attention to stigma and communications. I'm so glad that I'm speaking to the communicators today because we need your help. We know that people want to address these concerns, but frankly, they want someone else to take care of them. They want them to live somewhere else. They want them to be somebody else's problem. So how do we help the public and clinicians recognize that these patients are in their practice, they're in their neighborhoods, they're in their communities. And by embracing them and figuring out how to provide the supports and interventions that are helpful, we can markedly improve their outcomes and frankly, the outcomes for all of us. We've been focusing on novel ways to address stigma. And as you have some new ideas, this is a new area for the National Institute on Drug Abuse and is one that, but frankly, we haven't solved. So we're looking for good ideas to help us address internalized stigma as well as explicit external stigma as well. Next slide. When we look at some of the material, we've certainly highlighted on our website how using the words in your publications can matter. So probably the main lesson I take out of this is please encourage person-centered language. One of my patients can refer to themselves as an addict, but I will refer to them as a person with addiction or a young adult with addiction or an older adult with addiction. I will use that person-centered language to emphasize that they have a condition separate from their, sorry about this, separate from their nature as a human being. Next slide, please. And finally, as we are focusing on trying to reduce stigma and change outcomes, we need to pay attention to the way that we sometimes want perfect outcomes. We want people to be abstinent. We want them to go to their 28-day inpatient stay, come home, and live happily ever after. That is a wonderful idea. And when that occurs, we celebrate it. But that is not a realistic outcome for many. So how do we make sure that we pay attention to improvements along the way? How do we celebrate progress towards a long-term recovery, towards long-term changes, as a way to help people have the hope, encouragement, and to really reach the goals and their full potential? That doesn't happen automatically. I don't have treatments that will turn these around immediately for everyone. I'd love to have those. We don't have those now. But we do have supports in the area of recovery and treatment that can make a big difference. And with that, I really want to, next slide, thank you for your attention for a few minutes today. I'm looking forward to the panel that I'll join in a few minutes. I just hope that you've recognized that while drug overdoses have declined, they remain at unacceptably high levels in terms of the number of people perishing in our country from drug overdoses at the present time. While it's the synthetic opioids are important, there's also multiple drug use and changing drug landscape that keep us all on our toes in the addiction space. FDA-approved treatments need to be emphasized, and while these can be chronic relapsing conditions, treatment matters and recovery is quite possible. So I really want to thank you all for your attention, and I look forward to the discussion in a few minutes.
Thank you, Dr. Compton, for that phenomenal overview of the landscape as it relates to substance use disorders, but opioids in particular as well, and for reminding us that recovery is possible, although it is a journey. So next, I'm excited to
Brittany, can I jump in for 1 second before you move on and just say the participant chat is still disabled, so folks aren't able to chat.
Okay.
And I didn't know if that was a quick fix, but I wanted to let you know the Q&A is working, so if folks have questions, we are taking them in the Q&A. I have a couple, but we can also hold them, Brittany, but I wanted to just let you know that folks aren't able to chat at the moment.
Okay, let me just double check and see if I can fix that really quickly.
While you do that, I will, if you don't mind, Dr. Compton, I can share one question that we have here from participants for you, which is, folks are wondering, what do you attribute the decrease in opioid-related deaths over the past 12 months to?
Well, I'd love to have a very specific answer, and I know a number of researchers that are trying to disentangle, what's the role of public health officials? What's the role of our extensive distribution of naloxone and buprenorphine? What has been the role of drug interdiction or changes to the drug supply? The short answer is we believe all of these have had an impact, and I can't single out any one of them as being the magic inspiration for this improvement. I will say that I've been particularly impressed by changes in the drug supply. Just like we saw changes in the drug supply being responsible for the increases, and we've seen the potency of fentanyl changing that may have played an important role. I also think there's been an unfortunate learning process. Fentanyl spread across the country, and it only reached sort of the Rocky Mountains and West Coast in the earlier part of this decade, so 3 or 4 years ago. And as it hits different drug-using populations, I may be familiar with it as a national expert, but that doesn't mean that the group of injection drug users in Vacaville, California, had really paid that much attention until suddenly their drug supply was different. And a very lethal set of drugs entered those markets. And every time we saw it increase, enter a market, we saw a market increase in deaths. But there is a learn. People don't want to die when they use these drugs. They want to get intoxicated or address their withdrawal symptoms, but they don't want to die. So there is a learning process as well among the particularly the heavy drug users. That's not quite as clear for those who are what I think of as, you buy a pill from some unscrupulous person, you don't realize that it has poison in it. But that's a slightly different population where we need different approaches.
Great. Thank you for that. Brittany, I can pass it back to you if you are ready.
Thank you. And I would like to ask, for some reason, I'm not seeing an enable chat button on this view for me. So if those can use the Q&A function, I think that will be easier for us today. All righty. Alrighty, so we have two other panelists that will be joining Dr. Compton in conversation shortly. And so I'll introduce the first, Ms. Shauna Newton. Shauna is a senior manager of research and strategy at CMR Ignite, and she is experienced in public health campaign development, but in particular has worked with states across the country, specifically Maryland, DC, and also West Virginia with substance use disorder campaigns and program development. Shauna brings experience conducting research for understanding substance use disorder at the behavioral as well as the community level. And she's also been on teams that develop education and outreach campaigns to equip both local stakeholders with the data insights, but as well as the empathy that is required in developing trauma-informed communication materials. So welcome, Shauna.
Thank you for having me.
And last but not least, Dr. Marvia Jones, the director of the Kansas City Health Department. Dr. Jones has been working in the field of public health for 15 years with a special interest in violence prevention and health policy, both of which were honed during her time at the Centers for Disease Control and Prevention. While at CDC, Marvia evaluated the effectiveness of prevention tools provided to state and local health departments. She has since been an advocate of municipalities responsibly investing in opioid settlement funding, particularly to expand their capacity, their resources, and services to fill the gaps in communities for local opioid treatment and prevention. She previously joined the National League of Cities to share best practices and emerging strategies for investing opioid settlement funds, ultimately to maximize community impact. So welcome, Dr. Jones. All right. Well, our first question, I'd love to start the discussion around state and local health department efforts for opioid response. Many of our registrants on the call today are dialing in from various cities and states across the country. And so my first question, Dr. Jones, is how can local and state health departments improve their reach as well as their engagement with the public, specifically to provide credible, accessible resources and information that are tailored to individuals across the continuum of opioid use or misuse, or even their treatment and recovery journeys?
Yes, thank you very much, Brittany. Glad to be here. To start with that question, I would say that the first thing that we found was really necessary, and even cases we had to backtrack, was to really have a deep understanding of what was happening at the local level. So we sort of started initially with, we've got our medical examiner reports, and we know how many people have fatally overdosed in the past, year or so, or a couple years ago with the way our data works. So we had those numbers, and you take those numbers and you think, okay, we know what's going on. These are the zip codes of the folks, and this is the number of fatalities. Let's create some programs, or let's create our approach. What we found very early on was that we had to really partner with the different peer support groups and different opioid response or substance use groups that were already working in the area because they had way more intel. So we realized that the approach needed to be localized, not just for our city, but for even different pockets of the city, different age groups. We really were just kind of blown away by how segmented or fragmented the affected groups were. There were people who had been involved with the criminal justice system versus people who had come, as Dr. Compton mentioned earlier, people who had initially been prescribed medications, and then some folks who came they started with the illicit trade. Each of those groups, we learned from our partners, had a different set of needs, and the approach had to be different. So it was not a monolith. And so that was step one, to really understanding what the needs are. We started talking to families who had been affected, really getting that rich, colorful history of what's going on beyond just kind of these are the rates, these are the zip codes. That I would recommend as the first start is really taking time. Sometimes when we're in the middle of this type of crisis where we're like, oh my God, these numbers are going up. What's going on? We got to do something. Let's just start a program. Let's start funding something. You miss the collection of this sort of rich information that they can tell you when you really get down there to listen.
If I could add a little more to that, I hope that you heard in my presentation the importance of understanding your local situation. That I presented national data, but that's not what's happening in your community. You need to know what's happening there.
Mhm.
As Dr. Jones was pointing out, there are wonderful resources in every community. You might look even for the prevention coalitions. Many communities have community anti-drug coalitions, and their focus is not so much on treatment and recovery, but they are often engaged with many of the same people. And be creative in who you include in your partners in this effort. You know, law enforcement, healthcare, substance treatment, prevention, education can all be key partners in figuring out what the local strategies are best should be.
I'm curious, Dr. Jones, as well, what are some of those local data points? I know that I've heard that your team, for example, has engaged in some local tracing of overdoses and follow up with individuals who survived. What data from those experiences or other data points are you all using to drive your local strategy?
Yes, so some of the data points from perhaps the interviews that we're doing with people who have been affected or their families for obviously for non-fatal overdoses, we're asking questions sensitively and hopefully around what systems have you tried to access in the past? Where has where have you sought help before? We're finding that most folks we come in contact with have either been referred previously to some kind of support, or they've looked something up but got frustrated and never quite landed somewhere. And so we asked them about that. That's a data point that we're looking at, how many people have actually entered the system and then exited it without getting what they needed, as well as signs and symptoms and awareness from the family. We are very curious about, are family support sufficient, or what additional family supports should be provided for a group who's saying, hey, I see something's wrong. I see my family member or my loved one struggling. How can I support them? That has been a very helpful data point, something we're tracking, as well as the results from the Fatality Review Board that we stood up. That has also been something that we've been trying to glean from. Again, perhaps unsatisfyingly, we have found just from the few cases we've already taken through the review board process, each case has been so different. It's been so difficult for the group to really glean real commonalities beyond people tried to enter the system, but because of the fragmentation in the substance use support system, they have not been able to get what they needed. Otherwise, it's just been very different walks of life, different circumstances that led them to kind of spiral into an overdose. So many different things, and that has been fascinating to see.
And Shauna, I know that you have worked previously for organizations like NACCHO, really engaging closely with states and cities across the country. What is your insights glean in terms of your work from a research perspective, informative research that helps design some of the campaigns for opioids?
Absolutely. So I think what Dr. Compton and Dr. Jones have been mentioning in terms of the local approach is right on the money, and is a ton of the work that we've done in terms of supporting states and local health departments in addressing the opioid crisis. So really, an approach that centers first responders, that centers people in the community that are having touches with and an impact on both people who are living with opioid use disorder and the folks supporting them. has been crucial in evaluating those efforts. We've learned that those kind of wraparound approaches in campaigns do have better outcomes, right? So taking into account things like people's interface with the criminal justice system or with hospital systems, social workers, education systems and schools. Those are all things that have proven to be, again, more effective in terms of the outcomes that people have in the long term.
I think that one of the elements that I'd love to resurface the conversation on from Dr. Compton's presentation is stigma. I think that having a conversation around stigma is always a critical conversation as we think about what else is impacting someone's recovery journey or their decisions or attitudes towards seeking help. Or even the role of public health departments or healthcare providers in helping them along that recovery journey. So I'd love to talk a little bit more about the resource, Dr. Compton, that you shared about Words Matter and how you all got to the point of developing a resource like that and thinking about the role of those with lived experience and helping shape resources like that we can share with each other.
Well, this started with work that the National Institute on Drug Abuse supported, at least as I'm familiar, it may have started elsewhere, but through John Kelly in Boston. And they did quite a bit of work looking at if you just change the words of how we describe our patients, what does that do to even clinician attitudes? So they did a study that I'm familiar with that where they presented to several hundred clinicians a vignette. So a little description of a patient saying, I'll make this up. Mr. Jones was a 36-year-old male who presented to the emergency room with alcohol abuse. In the next version, they would say, Mr. Jones was a 36-year-old male who presented to the emergency room with alcohol use disorder. The word abuse, when it was used to describe the condition that somebody had, engendered a more negative attitude towards patients. Everything else was identical. So it seemed kind of surprising to many of us that even clinicians would respond differently when you just change that one word. So that was at the start of some major national discussions around words, and put our heads together and came up with some ideas. And the NIDA Med program, which unfortunately is no longer actively being supported, but the materials are all available on our website, is a resource that you all are able to access for information about that. And we're not the only ones. The American Society of Addiction Medicine, the Office of National Drug Control Policy have all emphasized, and SAMHSA have all emphasized the importance of our language. And frankly, that's something that maybe is relatively straightforward to address. There are other forms of stigma in terms of that are maybe a little more entrenched and difficult.
Shauna, I know that some of your work involves testing messages and testing concepts for materials as well as for campaign themes. Can you talk a little bit about what that process entails and how you've seen that be effective in ensuring the content or the messaging and resources that are developed really resonate with communities?
Absolutely. So, just driving home, obviously, employing best practices in describing those who live with opioid use disorder is like the first step there. But at CMR Ignite and much of the work that I've done, really taking a community-based participatory approach to testing these messages and testing these communications with the people who are actually impacted is very important and goes a long way in ensuring that what is said and conveyed to them is resonant, is empowering, and centers really important things that we want to get across, right? So when we talk about substance use disorder, we want to convey, obviously, that it is, a chronic and treatable disease that is common, right? That many people kind of have to walk the path of. And again, it's something that is exacerbated by upstream social factors and social determinants of health. right, driving those points home. And so we enter our message testing, kind of testing of materials with those things in mind, to ensure that we are framing those up properly, again, in a way that feels accessible, is plain language, and really is going to resonate with people who are living with substance use disorder and their loved ones.
Thank you. Thank you. And I like how you mentioned the social determinants of health, because I think, as Dr. Compton mentioned, healthcare providers, for example, and access to treatment or care is certainly one of those determinants. But I'm curious from the panel to talk about how you've seen other social determinants impact someone's recovery journey. So, for example, access to transportation to get to the doctor's appointment, or language barriers, and access to in-language materials, or anything else that you've seen really driving that.
Well, one thing to keep in mind when it comes to transportation is I kind of assumed this was mostly an issue for rural or more distant populations. Turns out that's not true. Urban areas have major transportation barriers as well. And that once somebody pointed that out, I would get, well, of course, because if something's only 3 miles away in a dense urban area, that may be 45 minutes. That may be the same as being 20 miles away in a place that has decent and easy access to high-speed roads. So I just point out that this has been a barrier, and we have seen how important that can be to address. It's one of the reasons why I think telemedicine has some really nice evidence for it being very helpful in helping people stay engaged in care, because you can use two-dimensional means like we're using today to reach people, and provide really life-saving healthcare to them.
Thank you. And Dr. Jones, I'm curious, what cross-sector or community-based organization partnerships have you all engaged in to try to address some of those social determinants of health?
Yeah, so we have partnered heavily with our local hospitals, and we are having ongoing discussions and sort of um, restorative discussions with them around how do we better serve people who are seeking help.
Well, I think there's a slight delay for Dr. Jones. So we'll pause. I think that we can actually shift to some of the Q&As that we have received. Um, so I will pause to pull those up.
We'll certainly hope that Dr. Jones can rejoin us.
Yes, I hope
I made a
so.
mistake in talking about
It
two-dimensional telemedicine.
might as well be never for some people. And so that has been a huge problem. Um, And those are two sectors that are engaged. We also find that we are intersecting even with just general health care. So we know that you mentioned the question around social determinants of health, access to insurance and access to somewhere to stay. A big part of our challenge has been people who are experiencing homelessness that is compounded by substance misuse, particularly opioids. Um, they may have a health condition. We've had people who have surgical procedures, but they can't stay in the hospital to recover because of their active substance use concern, and the other place isn't able to take them. And so some folks are being just released. And so we realized very quickly, okay, we've got to fund respite care for folks who are both dealing with trying to heal from a medical concern as well as a substance use concern. They may not quite be ready or haven't been in recovery long enough to be housed at some of these other shelters or other things. So they need their own respite care facility. So that has been a complicated piece that's compounded by, we're talking somebody who's got, you know, a violent injury, a gunshot wound, or someone who has heart disease and they've had heart surgery. How do you deal with these issues and the recovery from, simultaneously two major issues at a time? And so that's where we're seeing a lot of problems where our current safety net system is not equipped to handle that. And so the opioid settlement dollars have come in to kind of patch up gaps, and try to say, hey, well, what additional capacity do you need? How many more bed? We're talking about beds. How many beds could you use, and how many more staff so that this person who's recovering from something physical can also be there for and receive the other treatment as well. Medication assisted treatment is a big part of that discussion, but how does that coincide with the other prescriptions that they're taking at the same time? So we're finding that there's no singular pathway and no singular kind of shape of need for folks. It is expansive. People are still dealing with health crises at the same time as they're dealing with some of these. They're still dealing with isolation. And so we found, I had a lovely meeting with a faith leader yesterday about what is now the role of the faith community in helping to kind of do these supports. We see a lot of faith leaders who are doing a lot of the recovery groups and peer support groups. How do we lean more into them? So that's another sector that we're trying to re-engage, despite there having been some, faith system disengagement over a past generation. So how do we tap back into that? Because we know for sure local government and state government and whomever else is not going to be able to do this alone.
Thank you. And I like that you brought up the medicated assistance. We did have a question in one of the chat that says, I have heard some resistance around the use of medicated assistance, with too many saying that it is yet another drug that people take and can become dependent upon. Their question is, how can we message the benefits of these medications?
Well, I think some of the best ways to message it might be with persons who have been using medications and are successful in supporting a strong recovery. That those can be some of our most powerful messages. That my information from as a scientist and as a clinician will move a certain distance, but there's a really important role for personal stories as a way to really provide the emotional resonance that people need to change their minds about that. These are not ideal medications. I would love something that would simply turn our brains around and not allow us, and not have any desire, urge, or need for these habit-forming substances. I don't have that. But what we do have are ways that can really assist people in surviving and in making meaningful improvements in their life.
And I think just to speak to this also, Brittany, and dovetailing off of what Dr. Compton just kind of mentioned was that, this all gets into the principles of communicating harm reduction and the value of harm reduction. And obviously, storytelling is a really powerful way to do that in terms of kind of providing color to some of the context in which people have, entered the journey of substance use disorder, what they experience with opioid use disorder. And again, showing that it is something that can be a part of any person's journey, and really having those people themselves kind of chart the course and talk about, successes that they've been able to have and additional time that they've been able to have with their families through things like medication assisted therapies, right? So really approximating those experiences to other individuals so that they can understand the value of something like MAT.
Thank you, Shauna. And thank you for bringing up, the term harm reduction. One of the questions in the chat mentioned, how can outreach strategies be used to build awareness around harm reduction strategies, especially those strategies that are deemed more controversial? They said, namely, safe consumption sites or needle exchanges, which we have data to support, but remain less accepted in the fight against opioid overdose.
Yeah, definitely. So I think, again, it comes back to the power of storytelling and having multiple stories told by different individuals who have kind of walked that path. And again, having them talk a bit about, you know, what their journey has been as it relates to really engaging with harm reduction and different therapies that, again, at the end of the day, have been able to keep them alive, right? So that they may have been in the throes of active, you know, active addiction and been kind of on that course. But again, because they were able to use safely, or because they were able to call someone, like there are interventions available that allow people to get on the phone with someone if they've just used and they're afraid that something may happen to them, right? Like what all of those have been able to provide to them in terms of their experience, and navigating really the stress of that, and what impact that has on them as a whole. So I think, you know, telling those stories, making sure that people understand what it is like on a day-to-day, can do some of that work.
And can I add to that,
Absolutely.
Brittany? I would say, I think that totally makes sense. The storytelling around it is very helpful. I think instead of going and saying harm reduction in some spaces, something saying basically what Shauna just said about this is a process that keeps people alive as they are attempting to move to recovery. You know, something using those very clear words. And at the same time, I think just some acknowledgement that some parts of our country and some of our jurisdictions will never accept that in that way. And so presenting that range of options of approaches is always going to be helpful. I'm in Missouri. Missouri has been on the chart for quite a while as having problematic substance misuse, opioid from the whole range back to the 80s that Dr. Compton showed. And still, we're in a place where harm reduction is not a concept that is broadly accepted by the folks who write our legislation and the folks who, I mean, whether we're talking about at the state or the local level. And so I think that just keeping in mind that we will never look like New York City or Philadelphia, or the West Coast in some of the things they've been able to do. But what can we do for us? And y'all don't laugh at me, but you know, for us being able to do fentanyl test strips, and some regulated syringe exchanges was a win for us, and just in the past year. Other folks have been doing that for years, but to be able to do that locally was not something that was allowed prior, or some people weren't sure. It made it almost sound like you could go to jail for helping to distribute some of these things. And so that's a far cry from some of the things that have been mentioned before, like the supervised use and all of that. So it's just very interesting, and I try to live in the reality of where we are and what can we work with in our space to help people while we can. That may apply to some folks on a call. So
Thank you. Thank you.
I would just want to point out that uh, harm reduction services can often be an entry point for somebody to move towards
mm,
recovery in the long run. I do have a goal of helping people move towards recovery. That I'm a clinician and I want people to live productive, healthy, happy lives. But I understand that they may not want to come to any healthcare setting because we've treated them so badly over the years. And so going to a place that might treat them at least gently and kindly and offer some kind of support can be the beginning of people moving towards a pro-social positive outcome. But you have to have a long-term perspective with many of our patients.
mhm.
Thank you. And our final question, Dr. Compton, I'd love to share this with you. This question, I know that, you know, your career has primarily been at the national, federal level, but is there one thing that you would like for state and local health departments to consider when they're developing some of their opioid prevention and treatment efforts?
Well, I hope that they will look comprehensively at the full range of services that are needed. In other words, there's this idea that, oh, I just need more drug treatment. Well, transportation may be something that's essential to provide depending on the needs of your community. Supportive housing may be more important than another drug treatment program. there can be a variety of needs that are established. And so, as was highlighted early in this discussion, a full needs assessment of your local or your full state level is absolutely essential as you figure out where's the smartest place to put, even if they're significant funding, it's still quite limited. So where can we have the biggest impact?
Thank you, Dr. Compton. Well, I know this is a lot of content, and we wanted to make sure that we do leave some resources for those of you all who are attending the webinar. There are several resources that we will leave in the chat, as well as highlight here. CDC has a evaluation profile for implementing overdose communication campaigns. That is a resource that is walking you through the process for developing a communication campaign centered around overdose prevention, and includes things like logic models and indicators that you would use on the front end to plan how you would evaluate your efforts. Similarly, CDC Foundation also has a new Overdose Measures Matter resource that came out earlier in the summer that includes some of those indicators as well to ensure that the measurement of your efforts is consistent, and helps you understand the impact of your efforts over time. Lastly, the Opioid Use and Recovery Alliance, we actually have a couple of guidance articles, and we'll continue to develop webinars like this where we can come together as communicators to think about the different challenges, but also some potential solutions as we develop strategies for public education and outreach. So I will pass it over to Stacy to close us out.
Great. Thank you, Brittany. And I want to thank all of our speakers today and also our sponsors, CMR Ignite and the Opioid Use and Recovery Alliance, for leading and putting on today's webinar. And here's my 1-minute plug for the Society for Health Communication. If you are already a member, thank you. If you are not a member, I hope you will join us. Membership is free, and it comes with a bunch of perks, including things like discounted access to the Journal of Health Communication, where you can read about a lot of promising communication practices and interventions like we talked about today. In addition to our webinar series like this one, we also hold an annual summit each year, which is usually in June. So we hope that you will mark your calendars for our 2026 summit. We also invite you to engage with us on LinkedIn, send us suggestions for future webinar topics and speakers like this one that we had today. And then lastly, if you won't mind taking a moment to tell us what you thought of this webinar, we have a brief survey which was going to go in the chat, which may not be enabled. So that will go out in your email to all of you who registered and participated today. So please share that feedback. Thank you for joining us. There was incredible engagement in the Q&A, so we weren't able to get to all of them, but I'm glad that we got to some of them, and I hope that you all have a great rest of your day.
Thank you, Stacy. And yes, we will send out a post-webinar survey to the emails that you all registered with, and just really appreciate your attendance as well as your engagement in the chat. All right, have a great rest of your day, everyone.
Bye-bye. Thank you.
Bye.